Hi everyone, welcome to our first BIMA event of 2021. I'm Sarah, I'm the academic lead for BIMA. We're also joined by a number of our committee members, including Amar, our president, and Shabini Maharsh, our clinical leads. Today's talk will be on endocrinology and will be delivered by Dr. Aaron Patel. Dr. Patel is an academic foundation doctor in the West Midlands, doing his AFP in endocrinology. And yeah, I'll let Maharsh go through a couple of housekeeping rules before we begin, but I hope you will enjoy.
Yeah, hi. Just if everyone could please put themselves on mute, and if you've got any questions, just feel free to put them in the chat. I'm not sure if Aaron wants to answer them as we go along, or answer them all at the end.
What we'll do is we can just I'll have a look every so often and see if there's any questions that are coming up.
Yeah, okay. So feel free to put any questions on the chat, but please just try and stay on mute, just so that everyone can clearly hear what's going on and there are no distractions for Aaron. Okay, but that's it. And just thank you very much to Aaron for agreeing to host this session.
Okay, so hi everyone. So I'm Aaron. I'm an academic foundation doctor in Coventry in endocrinology, and so I've been asked to give you a talk about clinical endocrinology and cover most of the key areas that typically come up in exams. So just a bit of an overview. So we are going to be covering a lot this afternoon. So going through most of the key endocrine systems, and so covering thyroid, adrenal, pituitary, diabetes, your sodium calcium balances, and also just a brief overview of men as well. So we'll get started off with a question. So a 54-year-old female has presented to her GP recently complaining of being tired despite very minimal activity. And she reveals that she's feeling cold and also constipated. On examination, there is a smooth, uniformly enlarged and non-tender goiter that is palpated. So what is the most likely cause behind her presentation? So, yeah. So if everyone could just vote about what they think the answer is. And I'll give everyone about 30 seconds. Okay, so the poll is now closed. So most of you put the answer C, which yes is the correct answer. So this patient is exhibiting typical features of hypothyroidism. So feeling quite tired, feeling cold, and feeling constipated are those clues in the question stem. And the fact that she has a goiter points towards Hashimoto's thyroiditis. And the fact that it's non-tender also is a clue towards that. If it was a tender goiter, you may be inclined to put de Quervain's thyroiditis or subacute viral thyroiditis. And that could be in the hypothyroid stage of that disease. But in this case, because it is non-tender, it is going to be most likely Hashimoto's. The reason it is not primary atrophic thyroiditis is, as the name suggests, is that in that disease, the thyroid gland has atrophied, so there wouldn't be a goiter that you would feel. Graves' disease is a hyperthyroid condition, so that's not the correct answer. And it is unlikely to be a benign pituitary tumor in this case, based on the fact that there's a goiter there. So now we're going to touch over hypothyroidism as a condition. So as you can see in this picture, nicely illustrates some of the key features of hypothyroidism, and we'll be covering those over the next few slides. So what are the most common causes of primary hypothyroidism? So hypothyroidism can be divided into primary and secondary, as most endocrine disorders can be. So primary hypothyroidism is characterized by having low T4 or T3, so the hormones that your thyroid gland is producing, and a high TSH produced by the pituitary because of reduced negative feedback from the thyroid gland. So most common cause are the autoimmune causes. So they'll be typically seen with autoimmune diseases, and these include Hashimoto's thyroiditis, where you get lymphocytic and plasma cell infiltration of the thyroid gland, so it becomes hypertrophied, and you get a goiter. Primary atrophic thyroiditis, where the thyroid gland is infiltrated again, but this time the thyroid gland atrophies, and also in postpartum thyroiditis, again, after your initial phase of hyperthyroidism, when the thyroid hormone stored in the gland is released, because of the damage caused by the inflammation, there's then a period of hypothyroidism after that. Other common causes are after interventions or treatments, so iatrogenic causes like thyroid surgery or radiation therapy. A cause probably less common in this country, more common worldwide, is defects in actual synthesis of the hormone, most commonly iodine deficiency. And there's also drug-induced causes, but also dyshomogenesis, so just defects in the actual production of the hormone. And then there are some other less common causes at the bottom, so infiltration of tumors and congenital absence of the gland. And I already touched upon viral thyroiditis. Then secondary cause of hypothyroidism are where you have sorry, that's incorrect. Should be low T4, and you'd have low TSH, not high TSH, because your pituitary gland is where the problem is. So this is much less common than secondary disease, primary disease. And all causes of this include things like pituitary tumor, pituitary surgery, and radiotherapy targeted at the pituitary gland. I'll talk more about hypopituitarism later in the talk. So features of hypothyroidism, there's a long list here that I've given you, but the main thing to remember, especially if you are being vivid on these topics, is just that thyroid hormone is responsible for regulating metabolism in the body. So when you have a deficiency of thyroid hormone, your body's metabolic processes slow down. So the easiest way to think about it is what would happen if everything in your body slowed down. So you would feel constipated, you would feel tired, you'd feel cold, you'd feel depressed, and your appetite would be poor. And a common thing that people often forget to ask about when taking a hypothyroid history in women of reproductive age is asking about their menstrual periods, because often in hypothyroidism, women tend to notice that their periods become heavier. And so these are all various features of hypothyroidism. I won't labor all over all of them, but you can have a look at those in your own time. So investigations for hypothyroidism. So first of all, we need to confirm the diagnosis, so doing your thyroid function tests. And as I said, there will be a low thyroid hormone, and TSH would be altered depending on whether it is primary or secondary disease. If you want to investigate further, you can then look at thyroid autoantibodies, and typically in hypothyroidism, especially Hashimoto's, you'll get a positive thyroid peroxidase antibody being present. Hypothyroidism is also associated with anemia, typically macrocytic. So when you have a patient who's feeling tired and fatigued, it could be the hypothyroidism that's contributing, but also the anemia is having a role in that as well. Management of hypothyroidism is very straightforward. You just have to replace what's missing. So you give them some levothyroxine. Typically, we give about 50 micrograms a day and then titrate to get the TSH or free thyroid hormone in the normal range as we want. If the patient is elderly or has pre-existing heart disease, usually we start with a lower dose, just because thyroid hormone, because it's meant to stimulate activity, it can actually contribute towards ischemia of the heart if we're not careful. So when hyperthyroidism reaches an extreme, this is caused myxoedemal coma. So this is an extreme of hypothyroid disease. Typically, there's an underlying trigger, such as infection or MI. And as I said, the presentation is the extreme hypothyroid. So they would be extremely cold, hypothermic. Their reflexes would be suppressed. They'd often be very drowsy or even comatose, and their glucose would be low. So to correct this, we correct whatever is wrong. So if they're hypoglycemic, we need to give them glucose. If they're cold, we need to address the underlying hypothermia. But to address the thyroid disorder, instead of giving levothyroxine, which is T4, we instead give leothyronine, which is a T3 analog. And this is much faster acting, which is why we use it in these cases. And then we'll switch over to oral T4 once the patient is more stable. I just noticed we have a question. So would you still consider Hashimoto's thyroiditis if the cause is from another autoimmune disease like type 1 diabetes? So Hashimoto's thyroiditis is going to be based on the Hashimoto's thyroiditis is going to be based on the clinical picture as well as the autoantibodies that are present. So in Hashimoto's, you'd have the thyroperoxidase antibodies, which are positive, and you'd also have your goiter in your thyroid gland. Type 1 diabetes itself wouldn't be the direct cause of your thyroiditis, but it would be associated with the Hashimoto's itself. If that explains the question. And the second question I've got is levothyroxine safe in pregnancy? So yes, it is safe in pregnancy. Thyroid disease in pregnancy is quite an important topic. It's not something I'm going to cover in this talk. It is something that can be asked about in obstetrics. And it is important to make sure that the thyroid hormone is corrected in pregnancy, especially because it can have underlying effects on the developing fetus. And in fact, usually your thyroid hormone requirement actually goes up in pregnancy. So if someone is hypothyroid in pregnancy, we often monitor them very regularly and have to adjust their dose of levothyroxine to make sure that their normal range is being maintained. Why do steroids have to be used in myxoedemal coma? So yes, so the reason we have with steroids in myxoedemal coma is when we see the patient presenting immediately, we don't know whether it's the thyroid gland which is the problem, or whether it's the pituitary, and whether they're hypopit. And if they're hypopit, then is it universal hypopituitarism where their adrenals are also not functioning? And we have to replace hydrocortisone before replacing thyroxine, because otherwise this can actually precipitate worsening of the adrenal failure itself if they do have underlying adrenal failure and that's not been corrected. That's why we give hydrocortisone first, just in case. It won't do any harm to the patient. And in postpartum thyroiditis, so postpartum thyroiditis, if I'm honest, no one exactly understands the mechanism. It is very similar to viral thyroiditis in that pregnancy is a state of immunosuppression, just purely because we don't want the mother rejecting the fetus inside her. So the body naturally is immunosuppressed. After the baby is delivered, the immune system sometimes can hyperactivate, and this can sometimes cause inflammation in the thyroid gland. This is typically managed as viral thyroiditis. So in the hyperthyroid phase, usually you don't give antithyroid drugs, you would just treat symptomatically. In the hypothyroid phase, you can give replacement thyroxine if you feel that the patient is symptomatic. Is a goiter always caused by hypothyroidism? That not always, so I'll touch upon this a bit later. So goiter can be caused by inflammation of the thyroid gland, which can be both hyperthyroid in nature or hypothyroid, as the ones I've just explained. Goiter can also be caused by iron deficiency as the gland iodine deficiency as the gland hypertrophies to try and increase thyroid production, hormone production. So it can be hyper or hypothyroid. You just have to look at the clinical picture as well. And myxoedema, so it can be a bit confusing because it's used in both hyper and hypothyroid. So in this case, myxoedema, myxoedema in reference to myxoedemal coma is just a term used to define the extreme of hypothyroidism. And the reason it's called edema is because these patients do actually become a bit edematous if they've got extreme hypothyroidism. But I will just move on to the next SBA. So a 34-year-old female presented to a GP with irregular periods over the past few months. She's always feeling hot and her heart is racing in her chest. So on examination, she also has a large enlarged goiter, and blood tests show that she's got a TSH receptor antibodies positive. So what is the most appropriate so the question's missing here, but the question is, what is the most appropriate symptomatic treatment for her initially? So if we could have the poll up for that. So again, the question is, what's the most appropriate symptomatic treatment for her initially? Okay, and most of you have, so very close between A and B, carbimazole and propranolol. So the answer I was looking for in this case is propranolol, and some of you may be asking why that is. So this patient is hyperthyroid. You can see all the clues highlighted in the question about that she's hyperthyroid. This time she has the goiter, and just to address the question before about goiters, this is a hyperthyroid goiter this time, and she is, because she is hyperthyroid and she's TSH receptor antibody positive, the most likely underlying diagnosis is going to be Graves' disease, because the antibodies are basically pathognomonic of Graves' disease. The reason it's not carbimazole is because carbimazole itself actually takes about 4 weeks to work, and this patient's symptomatic now. So what you can give her is you can give her a beta blocker such as propranolol, and this is going to help with some of the symptoms such as the palpitations. This may not help with some of the other symptoms such as the irregular periods, but this will help really at least alleviate her to some extent symptomatically until the carbimazole or definitive treatment can kick in. Okay, so now we're going to talk about hyperthyroidism. So again, causes can be divided into primary and secondary causes. Your primary disorders are affecting the thyroid gland directly. Again, most common is actually your autoimmune disorders, and in this case it's Graves' disease. So again, there is an association with other autoimmune diseases, and you have these TSH receptor antibodies which are targeted against TSH receptor, both in the thyroid gland and in other tissues, which I'll cover in a second. Other causes are, again, your thyroiditis, but this would be in the initial phase of thyroiditis when the gland is becoming inflamed. As the inflammation occurs, your thyroid gland responds by releasing its stores of thyroid hormone initially. So usually you'd have an initial about a month period of hyperthyroidism before you have your period of hypothyroidism as the gland recovers after that inflammation. Other causes are pituitary tumors. Typically, if they're functional tumors, so they're producing hormone, they're usually going to be benign in nature. And these can be multinodular, so multiple small tumors throughout the gland, or usually a single thyroid adenoma. Again, secondary causes of hyperthyroidism are going to be from the pituitary, so a TSH secreting adenoma, which again is quite rare. There are some caveats to this. So there are some other causes which of hyperthyroidism. So there's both these, so you have these weird and wonderful tumors. So you typically get ovarian teratomas, which can secrete thyroid or analogs of TSH ectopically. And also you can have what is called a factitious hyperthyroidism, where someone may have taken sometimes accidentally or deliberately taken more thyroid hormone than they should have done. So symptoms of hyperthyroidism is basically the exact opposite of hypothyroidism. Everything in the body is going to speed up. So you're going to feel, so patient often, rather than gaining weight, they're losing weight. They're feeling hot. They often present as being quite anxious, so it can be often mistaken for them being quite panicky or having panic attacks, often very sweaty, having diarrhea and tremor. And instead of having heavy periods, this time they often have scanty or irregular periods. So these are just some of the features to watch out for when a patient's having hyperthyroidism. Again, if you're asked about this, just think about what would I expect to happen if everything in the body were to speed up. Now, Graves' disease, because it's the most common cause, there are some features which are exclusive to Graves' disease because of where your antibodies are acting. So your TSH receptor antibodies can also act on the soft tissues in the orbit, and this causes exophthalmos and ophthalmoplegia. So the patients often seem to have their eyes protruding, and also they have either reduced or incoordinated eye movements. Then you have pretibial myxoedema. So again, pretibial myxoedema, so someone's asked about pretibial myxoedema. So pretibial myxoedema you do not get in hypothyroidism. So the myxoedema in hypothyroidism is not the same as this pretibial myxedema. In hypothyroidism, it's used to refer to the hypothyroid state where you often get fluid retention and can become a bit edematous. In pretibial myxedema, you get soft tissue swelling of the shins, which is non-pitting. So it's not really edema to some extent. And finally, you get what's called thyroid acropatchy, which is just essentially clubbing. Because again, the TSH antibodies are acting there. Hyperthyroidism examinations are, so investigations are exactly the same as for hypothyroidism. So you look at your TFTs, you look at whether autoantibodies are present. If anti-TSH receptor antibodies are, then it's most likely Graves' disease. If you have a nodule or an adenoma in the thyroid gland, often the patient will be referred for an ultrasound of the gland just to make sure that the adenoma, especially if it's a singular adenoma, just to make sure that it's not got any suspicious or malignant features which need further investigating. If it is a suspicious lesion, then it will often be investigated further with a biopsy. As I said before, if malignant thyroid lesions are often non-functioning. So if they have got hyperthyroidism, it's unlikely to be malignant. Something which can be done, isn't done as much nowadays, is an isotope or an iodine uptake scan, and you can see how much the gland is uptaking the iodine to produce the thyroid hormone. If activity is increased, if it's locally increased, then that means it's often a localized thyroid nodule, which is hypersecreting your thyroid hormone. If it's something like Graves' disease, you'd expect the whole thyroid gland itself to be lit up and increase its iodine uptake. Yeah, so malignant lesions in the thyroid gland are usually non-functioning. I say usually because obviously, as with most things, there are exceptions. So lesions will be often ultrasound first to look at the underlying structure, and then if there are some suspicious features in ultrasound, it will then be biopsied. So management of hyperthyroidism, again, initially, as I said before, symptomatic control first, and then your anti-thyroid drugs are added in at the same time, and they'll take about 4 weeks to work. Two different strategies for anti-thyroid drugs. One is titrating the anti-thyroid drug itself to get the TSH in the range that you want it. The other strategy is called block and replace, where you give a high dose of anti-thyroid drug and you also give replacement levothyroxine. So you're essentially rendering them hypothyroid and then replacing the thyroid hormone. An important side effect, and one that often comes up in exams, is agranulocytosis in the use of drugs like carbimazole. So you often have to warn patients that if they become feverish, unwell, develop a sore throat, they should seek urgent medical attention, because it could be they have to have a full blood count done to make sure that their white cells are not depleted. So further treatments that are available are things like radioiodine and thyroidectomy. So often the treatment strategy is often left up to the patient. There isn't really any sort of defined order. In Graves' disease, because it is the whole gland that's uniformly affected, usually we would initially try with thyroid drugs for a period of about 12 to 18 months, and then stop the thyroid drugs and see whether they maintain remission of the hyperthyroidism. If the hyperthyroidism then relapses, we'd probably then consider a thyroidectomy or radioiodine treatment. Common side effect of thyroidectomy, besides them being obviously hypothyroid afterwards, is recurrent laryngeal nerve injury. Again, something that often commonly comes up. So the question about why we use beta blockers. So palpitations and AF. So they're at risk of developing really fast heart rhythms. So beta blockers are given just to settle any palpitations and further symptoms of anxiety, because thyroid hormone potentiates sympathetic nerve activity. So if you think about it, when they're hyperthyroid, the whole sympathetic nervous system becomes hyperactive. So beta blockers help to settle that. So it will help settle the sweating, it will help settle the tremor, it will help settle their palpitations and their tachycardia. That's why we give it initially. And again, with thyroid toxicosis, there is an extreme state which is called thyroid storm, where so this often happens after you've had an intervention like thyroid surgery, or it can be after something such as infection or MI. So again, it's the extreme of thyroid toxicosis. So they're often in AF or extreme tachycardia, confused, comatose, and extremely agitated because of this overactivity of the sympathetic nervous system. So how do we manage this? So we make sure they are fluid resuscitated if they're lacking fluids, because don't forget they're going to be sweating a lot, they're going to be agitated, they may be dehydrated. Going to give them their beta blockers to settle symptoms rapidly initially, start them at antiviral drugs that will be then continued long term, and we give hydrocortisone. The reason we give hydrocortisone in thyroid toxicosis is because it actually reduces the conversion of T4, which is relatively inactive, to the more active T3. So again, it should help settle the symptoms of thyroid toxicosis. And you can also help cool the patient if they're pyrexial by tepid sponging and also some paracetamol. Okay, so we'll now move on to the third SBA. So a 41-year-old woman is seen in the endocrinology clinic, overweight, and she's got weakness in her arms when she lifts up objects. So when you examine her, you see there's some bruising in her arms and some stretch marks on her abdomen. Her blood test showed elevated early morning cortisol. So what is the most appropriate investigation to do now? We start a poll for that. Okay, and so yeah, the answer, so most of you have got the answer right. The answer is D, so overnight dexamethasone suppression test. So this patient has some classical features of Cushing's, so overweight, proximal myopathy, easy bruising, and stray and stretch marks on the abdomen. And elevated early morning cortisol is usually the first test we do. So then to further investigate the Cushing's, first line test after an early morning cortisol is an overnight dexamethasone suppression test. Random plasma cortisol is not useful because cortisol levels change throughout the day. As you know, there's a diurnal variation. So we have to take that with a pinch of salt if we're doing a random cortisol. 48-hour dexamethasone suppression test is typically done after an overnight dexamethasone suppression test to both confirm the diagnosis and also to investigate the potential cause. Pituitary MRI would not be done yet because we need to determine that they do actually have Cushing's before localizing where the lesion is. Similarly, with an inferior petrosal sinus sampling, that would be done later on once we are trying to localize where the lesion is. I'll talk about these tests a bit later on. So we just have a question about the previous slide. How would you distinguish between a patient presenting with a thyroid storm or sepsis? The answer is you can't. Sepsis itself can trigger a thyroid storm. So you would be both. So you'd probably do your TFTs as part of your workup in your bloods, but you'd also be treating the underlying sepsis. So you'd be treating them at the same time for both things. Another question, do autoantibodies stimulate the TSH receptor? Yes, they do. In Graves' disease, yes, they do. So in Graves' disease, it is the TSH receptor antibodies which are acting on the TSH receptors on the thyroid gland and stimulating thyroid hormone release. So your TSH is then suppressed because you have reduced, because negative feedback from increased thyroid hormone production. Okay. So just moving on to talk about Cushing's. So Cushing's syndrome can be ACTH dependent or independent. So if it's ACTH dependent, it is it can either be the pituitary is oversecreting ACTH, so from a tumor. This is Cushing's disease, and this is the most common cause. Or more rarely, you get ectopic ACTH secretion from a tumor, such as a small cell lung cancer. ACTH independent causes, most common cause of these is actually a patient taking too much exogenous steroids. Otherwise, it is going to be excess steroid production by the adrenals themselves, whether this is an individual adenoma or carcinoma, or hyperplasia of both adrenal glands. So moving on to the features of Cushing's syndrome. So most of you obviously recognized it from the question itself, but most commonly they have these features of being quite overweight, usually more around the abdomen, so centripetal obesity, and around the face, and can get fat distribution into interscapular region. They are often very tired. They have infections, osteoporosis, and proximal weakness in their muscles. They also can have more psychiatric symptoms, so something like depression, psychosis, or being often very tired. And the third group of symptoms they often present with is actually gonadal dysfunction, because the steroid imbalance is altered. So in women, this is things such as disturbance of menstruation, and almost similar to PCOS, so they get excess body hair growth. In men, things like impotence, erectile dysfunction. And more other constitutional signs you may pick up are things such as hyperglycemia, a raised blood pressure as well. And as you said, the features we talked about in the earlier questions, so easy bruising and thinning of the skin and stretch marks. So a question about why Cushing's causes hyperglycemia. So it's because of the general action of steroids themselves. So when you think about it, steroids, one of the actions of steroids is to cause increased breakdown of, well, increased generation of self-glucose in the blood because of the stress response. It is a stress hormone, and in stressful situations, your body reacts by increasing your levels of blood glucose to ensure that there's more glucose available for tissues to use in metabolism. Why would Cushing's cause hypertension? So if the corticosteroid levels are high enough, they can actually act on mineralocorticoid receptors. That is why it can cause a bit of hypertension. So in terms of investigations, so I know someone asked about this earlier. So initial investigations, you'd find that they're often a bit hyperglycemic, and they would have a raised morning cortisol level. So once you have this suspicion, you can then do your first line tests. Most commonly now is an overnight dexamethasone suppression test. So you'd give them a load of dexamethasone at about midnight, and then the next morning at around 8 o'clock, you then measure their cortisol level. Their cortisol should be suppressed, but if it is not, then that's an indication that this is Cushing's. And another test that isn't used as much just because it's a bit more cumbersome is 24-hour urinary cortisol collection. Then we can move on to second line tests. So one of the second line tests is a 48-hour dexamethasone suppression test. One possible option is a low dose dexamethasone suppression test, which is more of a confirmatory test to support that they have Cushing's. The other alternative is a high dose dexamethasone suppression test, which isn't used that much anymore, which is meant to determine whether the cause is pituitary or non-pituitary. And the idea is that if it's a pituitary cause, it would still suppress their cortisol levels to an extent with a high dose of dexamethasone. As I said, it's not really used that much anymore. Then once it's determined that they do have Cushing's, their steroids are not being suppressed, then we have to localize where it is. As I said, high dose dexamethasone suppression tests aren't really used anymore. The main tests that we use are, as someone said, looking at the plasma ACTH to see whether that level is raised or suppressed, and that then gives us whether it's ACTH dependent or independent cause. If it's ACTH independent, then we can image the adrenals and do adrenal vein sampling to then have a look at whether there's any obvious hyperplasia or tumors in the adrenal glands. And the adrenal vein sampling is to determine whether the excess cortisol secretion is from one adrenal gland or both, because even if there is a tumor in one adrenal gland, we can't for certain say that there isn't excess cortisol secretion from the other adrenal gland. Sometimes these tumors are extremely small and they may not be picked up on the CT scan. And similarly, if plasma ACTH is raised, we do an MRI pituitary. Again, not all tumors are going to be picked up in an MRI pituitary. That is why we then do inferior petrosal sinus sampling. So if you go back to your anatomy, the inferior petrosal sinus is the venous sinus that your pituitary hormones are secreted into. So that will be then, so you analyze your venous blood from there to see what the level of ACTH is and see whether that's elevated. So just a few questions here. So I've talked about inferior petrosal sinus sampling, why that's done. So in terms of, and the other question is high cortisol, low ACTH means adrenal cause. Yes, so high cortisol and low ACTH is an adrenal cause, and high cortisol and a high ACTH is going to be a pituitary cause. But the important thing to stress is that you can't rely on just a single cortisol measurement because of this diurnal variation. Even an 8 a.m. one, you have to confirm that they do have increased cortisol secretion by doing a dexamethasone suppression test. And only then, once you know they do have Cushing's, you do your further tests like your plasma ACTH, your imaging, and your sampling to determine what the cause is. So management of Cushing's. So if it is iatrogenic, so your own steroids, or if the patient's on steroids, then you can cut back the dose of steroids if you are able to. Obviously, that depends on the reason they're on steroids in the first place. If it is Cushing's disease, so a pituitary cause, then you can resect the pituitary adenoma. If the Cushing's disease cannot be resolved by resecting the tumor, or not able to resect the tumor, or the disease recurs, then other options include bilateral adrenalectomy, so removing the adrenal glands and then replacing the steroid hormones, or you can use adrenolithic drugs, so drugs that suppress the production of steroids by the adrenals. If you have an adrenal adenoma, similar sort of principle, so you can use surgery and other means of treating the tumor, such as radiotherapy. If it is a carcinoma, then you might want to give further adrenolithic drugs such as mitoprene following treatment, and you need to do careful follow-up, make sure that there's no recurrence of carcinoma. If this secretion is ectopic ACTH, then you need to locate that source. Most likely will be a lung tumor, and then try and resect that tumor if you can. If you can't, then again, you can use these drugs which suppress adrenal steroid secretions, such as metyrapone and ketoconazole, while you are either awaiting surgery to happen or you're waiting for effects of radiotherapy to happen, because they won't be instant. Okay. So moving on to fourth SBA. So 35-year-old male presents for a checkup. Blood pressure is elevated, 160/120. He has ambulatory blood pressure monitoring, which shows that he does have hypertension. He has some blood tests which show that he's hypokalemic and also has raised aldosterone and low renin levels. CT abdomen shows as a tumor of the left adrenal. So what is the most appropriate initial management for this? Okay, so most of you put what is the correct answer, which is spironolactone, which is good. So this patient this is a very relatively young patient to be hypertensive, or to that extent, 160/120. And they also have hypokalemia. And when you put that together with raised aldosterone and low renal levels, this implies that they've got excess secretion of aldosterone from their adrenal gland, most likely this tumor being the source. So what definitive management would be to remove the tumor, but we need to get the blood pressure under control initially before they have surgery. So usually we would treat them with at least 4 weeks of spironolactone before we then they would then undergo surgery. Okay, so that's why that's the correct answer. Ramipril and amlodipine, obviously your more common first-line antihypertensives, but they wouldn't address the underlying aldosterone secretion. Metyrapone, as I said before, is a drug typically used in Cushing's to suppress cortisol secretion. Again, that can be used as an interim measure before they have their surgery for Cushing's. Okay, so now we're going to talk about primary hyperaldosteronism. So the most common cause is actually not Conn syndrome. So be careful when using terminology like this. So Conn syndrome just simply refers to an adrenal adenoma, so a single tumor that is secreting aldosterone. If most common cause is actually in fact bilateral adrenal hyperplasia, so both adrenal glands are hypersecreting aldosterone. Again, like Cushing's, another cause but less common is adrenal carcinoma. And for hyperaldosteronism, there is a fourth cause, so this glucocorticoid remediable aldosteronism. What that simply means is that their aldosterone secretion is under the control of ACTH. So so their controls now become independent of the renin-angiotensin system. So that can lead to hypersecretion of aldosterone. The symptoms of so features of hyperaldosteronism. So most commonly, they're actually asymptomatic, and it's just incidental hypertension that's picked up at quite a young age and is resistant to multiple antihypertensives. If it is more severe, then they can have features of hypokalemia, so arrhythmias, muscle weakness, polyuria, polydipsia, and some muscle cramps and pains. Is some of the more common features of hypokalemia. So how do we diagnose it? So because they've got excess aldosterone secretion, this means that encourages potassium loss and sodium retention. So sodium levels are either normal or raised and potassium is low. And because of this low potassium, they can get a metabolic alkalosis because hydrogen ions and potassium are often buffered by each other. So you then measure your plasma renin and aldosterone levels 2 hours after sitting. That's because when you stand up, it can affect, because you do get this initial drop in blood pressure, which then stimulates your renin and then aldosterone secretion to increase. It can affect the results of this test. You make sure that they've been sitting for about 2 hours, and then you take the blood test. And so your aldosterone will be raised, your renin levels will be suppressed as per negative feedback. Once you have this, you would then consider a CT abdo to then see if there's any obvious tumors secreting. And then, like for Cushing, you would then do adrenal vein sampling to see where this aldosterone is coming from. Is it one-sided or bilateral? So if it's one-sided, as in Conn's, treatment, as I said, is laparoscopic adrenalectomy, and then spironolactone for 4 weeks. Before that, to control the blood pressure and potassium. If it's hyperplasia, you wouldn't typically remove both adrenal glands, just because you'd have to then do replacement of all their steroid hormones for the rest of their lives. So much more easier to just treat with drugs such as spironolactone, which will antagonize the action of the aldosterone. If glucocorticoids are driving the aldosterone secretion, then you can give some DEX, which will, again, by negative feedback, suppress the ACTH secretion and then suppress aldosterone. If it is an adrenal cancer, then again, surgery, and then you'd have your post-op adrenoleutic drugs to prevent recurrence. So someone's asked, is bilateral adrenal hyperplasia the same as congenital adrenal hyperplasia? The short answer is no, it's not. So congenital adrenal hyperplasia is due to either a deficiency or complete inactivity of one of the enzymes involved in steroid hormone synthesis. It's a bit beyond the scope of this talk. It more comes under your pediatrics, but that's the so that's what causes congenital adrenal hyperplasia. That often presents a lot younger in children once they're developing through puberty. Bilateral adrenal hyperplasia typically occurs a bit later in life because it is just a natural hyperplasia of your adrenal glands. It's not in any way due to the enzymes not functioning. So why would glucocorticoids stimulate aldosterone secretion? So it's not the glucocorticoids, it is the ACTH. So there's a genetic mutation in, so the GRA is a bit of a caveat. It's not something that I don't think you guys need to labor over knowing, because it is quite rare. All that happens is that there's a mutation, which means that the gene for aldosterone is now under the control of a transcription factor regulated by ACTH. So ACTH is now controlling aldosterone secretion rather than renin. So that's why you give DEX, because DEX would suppress ACTH, and therefore that would suppress the transcription of aldosterone. Okay, so let's move on. So fifth SPA, so 28-year-old man complaining of dizziness and lightheadedness. Experiences frequently when he's standing up. He's lost some weight over the past few months, and on examination, his blood pressure is 121/82 when sitting and 175 when standing. And when you look at his hands, you notice his palmar creases appear a bit more darker. So what investigation would you do to confirm the diagnosis? Let's get a poll up for this. Okay, and most of you put A, which is the correct answer. So this patient, as you can probably tell, has dizziness and lightheadedness, lost weight, postural hypertension, and darkened palmar creases. So these are all features typically associated with adrenal insufficiency. So the gold standard test to confirm diagnosis is the short synaptin test. So you give them ACTH, and you see whether their adrenal glands respond and produce hormones. So serum long synaptin test still used. To my knowledge, it is not used that commonly anymore, and it's not something that you would probably need to be aware of for undergraduate exams anyway. So serum glucose. So this is a useful screening test because glucose is often low in Addison's or adrenal insufficiency, but again, we're not confirmed the diagnosis. Low dose dexamethasone suppression test I've talked about before is a test for diagnosing Cushing's rather than adrenal insufficiency. Serum cortisol, same reason why we don't use it as before. There is diurnal variation, so it's not a useful test alone to diagnose adrenal disorders. Abdominal CT would probably be done after shorts, can be done if you're thinking that glands have themselves hypertrophied, not hypertrophy, atrophied. We were looking for whether there's an underlying cause, but it wouldn't be used to confirm the diagnosis. Okay, so adrenal insufficiency. So causes of adrenal insufficiency, either primary or secondary. Primary causes are referred to as Addison's disease. So that's when the adrenals are affected. So a long range of conditions. In the UK, most common causes are autoimmune destruction of the adrenal glands. So again, would be associated with other autoimmune diseases. Worldwide, the most common cause is actually TB. Other reasons for the gland to stop working are infiltration of the gland, whether this is by a malignancy, whether this is by an infection such as HIV, or whether this is bleeding into the gland. Most common, it's not common, but the most popular one that people like to remember is Waterhouse-Friderichsen syndrome, which is adrenal hemorrhage following meningococcal sepsis. Again, it's something that people often ask exams. Patient has meningitis and now they're adrenal insufficiency. If they have secondary adrenal insufficiency, again, it's the pituitary that's causing it. So the most common cause is steroid withdrawal. So if they're on high dose steroids for a long time, their ACTH secretion by the pituitary has been suppressed for a long time. And when you take away these steroids, it takes a bit of time for the pituitary gland to wake up and start functioning again. So that can sometimes cause adrenal insufficiency, or any of the other causes of hypopituitarism can also cause it. Symptoms, so in the SBA talked about some of the main features. So you have constitutional features such as lethargy, tiredness, weight loss, pains, aches, dizziness, feeling a bit weak generally. Psychiatric symptoms, so again, similar to Cushing's, can sometimes be depressed or sometimes psychosis, and GI disturbance, so abdo pain, diarrhea, constipation, nausea, vomiting. So in any patient who has been on steroid treatment and is now coming complaining of abdo pain, diarrhea, vomiting, always think about, could this be adrenal insufficiency? And then signs on examination, postural hypertension, can have some hair loss. Again, this would be because of autoimmune, and hyperpigmentation of creases, of skin creases, scars, and also buckle in the mouth. So what is the cause of psychiatric symptoms? So if I'm honest, I'm not entirely sure. The steroid hormones do have delicate intricacy and interaction with neuromodulation. So I would assume that it is one of these CNS effects that is causing these psychiatric symptoms. And that's why we get it in both when there's too much hormone and when there's too little steroid hormone. In reality, I can't give you the exact mechanism. Again, what would cause the abdominal pain? Again, I'm not too sure what is the underlying cause behind the abdominal pain. I'm sorry, I'm not able to answer that question. Would be something that actually might be worth looking up after this, but sorry, I'm not able to answer that. But it's just important to be aware of that. That is often the presenting feature. Cause the pigmentation. So ACTH, when you think about the actual genes and the transcription processing that leads to ACTH production, the same gene that produces ACTH also produces MSH, which is melanin stimulating hormone. So that stimulates melanin production, which is obviously responsible for skin pigmentation. So if this patient, because of reduced negative feedback, has got over secretion of ACTH to try and stimulate steroid production, they're also going to get increased stimulation of melanin production. That's going to cause the pigmentation. Okay, so investigations of renal insufficiency. So again, do you use these? Right, just another question. How does pigmentation show up on darker skin types who have naturally pigmented creases? So in people with darker skin types, you probably wouldn't necessarily see the pigmentation on their skin. Here's the answer for that. So just talking about investigations for adrenal insufficiency. So if you do using these, because the whole adrenal gland is not working, you don't have any mineralocorticoid. So your sodium would be raised and your potassium, sodium would be low and your potassium would be high because you don't have that aldosterone action. And your glucose will be low because you'll have this low cortisol, your low cortisol. And as I said before, cortisol is the stress hormone and adjusts metabolic processes to increase glucose levels in the blood so that there's more available for tissues to use in metabolic processes. Okay, and yeah, someone's come to say, yeah, so that's right. So in darker skin types, as I did say before, you also do get hyperpigmentation in your gums and your buccals. So typically beneath the teeth, there will be hyperpigmentation. That should still be seen in people with darker skin types. As a gold standard diagnostic test is Torkson-Ackman test. And so you would administer this and see whether there's a steroid response. And if there is not, then that diagnoses the adrenal insufficiency. So then you can have a look at seeing where the cause is. So if it's autoimmune, a lot of cases actually have these 21-hydroxylase adrenal autoantibodies that are present in the serum. So these can be looked for. You can look at renin and aldosterone to see whether, to assess whether their mineralocorticoid production is affected. And as I said, most common cause worldwide is TB. So you may want to consider doing X-rays to see whether there's actually any evidence that they've had TB in the past. And you, as I said, you can do adrenal CTs if you want to see whether there's any infiltration of the adrenal glands on imaging. So why would there be uremia? There would be uremia just because they'd be dehydrated. So in adrenal insufficiency, you do get fluid redistribution, and you can become hypotensive. You get the postural drop. In more severe cases, this would then develop into full-on shock and hypotension. So you get uremia because you got a fluid deficit in the body. Okay. So managing adrenal insufficiency. So replace what is not there. So you give hydrocortisone replacement. So this is just an example regimen. The actual regimen they would have would be determined by clinician looking after them. This isn't something you would need to know. All you need to know is that you replace hydrocortisone, you replace fludrocortisone if they have an electrolyte imbalance or they've got postural hypotension, and you have to increase their steroid by about 5 to 10 milligrams before they do any strenuous exercise or activity. If the patient is unwell or they're going through any particular stress, such as trauma, then you need to double the dose of their steroids. So that's all doses for at least a week. If they're unable to keep down all steroids or are vomiting a lot, this could be a manifestation of their, this could be a sign that their adrenal function is worsening. So you would give them IV or IM hydrocortisone 100 milligrams to settle that. So someone's asked, steroids anti-inflammatory and decrease immune system, then why do you double steroid dose for patients who are sick? This is because in a stressful situation, so just remember, adrenal hormones like cortisol are the stress hormone. If you do not have cortisol, your body is not able to mount a stress response and will not be able to deal with increased stress in situations such as infection. So if you don't give them these steroids when they are sick, then they will then have go into an Addisonian crisis. And I'll touch on that a bit later on. So if someone has a stressful incident, our family members usually so why we add hydrocortisone before strenuous exercise? As I said again, strenuous exercise is a stressful situation, albeit a shorter term one. That's why we give them a top up of their steroids so that their body is able to deal with this increased stress. So cortisol is an incredibly complex hormone in terms of its interactions with the whole body. It's responsible for regulating a whole number of different body's processes in response to stress, such as exercise, such as infection, such as trauma, operations. That's why we need to supplement it if the body is coming. But then won't stay. So in response to infections, so steroids are responsible for immunosuppression, yes, but this would be if they were given extremely high doses of steroids for a long period of time. We're giving these high doses of steroids for a comparatively short period of time. So we won't be overall suppressing their immune system to that great extent. And in these cases, we have to think about what is going to kill the patient first. Is it going to be that they're not able to mount a stress response, or is it infection? And in these cases where their adrenals are failing, it will be that they don't have enough stress hormone to deal with the stress that they're having. Okay, and okay. And so as an Addisonian crisis, so if they do have, so as I said, infection, trauma, surgery, or if they haven't had their steroid dose, if the steroids aren't adequately increased, then they will go into Addisonian crisis where their body isn't able to cope because they don't have enough steroid hormone. So they will go into shock, they'll become hypertensive, hypoglycemic, and they will often go into a coma. So this is an emergency. This is one of a number of endocrine emergencies where you need to give them IV fluid resuscitation, start them on your IV steroids and regular IV steroids, and also regular IV antibiotics, especially if you're suspecting that there's an infectious cause. You don't need to give them replacement mineralocorticoid like spironolactone in crisis, because the high doses of hydrocortisone given will be able to stimulate the mineralocorticoid receptor. After about 72 hours, if the patient is improving, you can then swap them over onto oral steroids. Again, still higher dose, and then you can titrate down as they improve. And again, they're often very hypoglycemic because they don't have the steroid hormone to help release glucose from both their fat stores and other stores in the body. So they may need some IV glucose as well if they're very hypoglycemic. If someone with Addison's has a long-term illness, how long would you continue a double steroid dose? So this isn't for long-term illnesses where you double the dose. This is for acute stressful reactions. So if they suddenly become unwell with an infection, if they've had a major trauma, if they're having surgery. So this wouldn't be, so if someone's got a long-term illness, such as let's say something like, I don't know, something like rheumatoid arthritis, that wouldn't count as an acute stressful a time of acute body stress where they need increased steroid. After doing a shorts and actin test to look for steroid response, are we measuring cortisol aldosterone levels too? So after the shorts and actin test, you're going to be measuring your cortisol levels, because ACTH shouldn't be affecting your aldosterone levels. You'll do a renin you'll do renin and aldosterone levels as a paired level measurement, because renin and aldosterone are self-regulating of each other. So moving on to SPA6. So a 45-year-old woman sent to ambulatory care by a GP. She's had 4 panic attacks a week recently with heart racing, headaches, and excessive sweating, but they soon subside. Urine shows elevated 24-hour methanephrin, and the abdo-CT shows a unilateral adrenal tumor. So what's the most appropriate initial management for this patient? Okay, most of you have put the answer D, soprano followed by phenoxybenzamine. So that is, that is not correct. So the correct answer is phenoxybenzamine followed by propranolol, and I'll go on to this in a bit. So this patient, they've got these recurrent episodes of heart rate, of tachycardia, palpitations, headache, and excessive sweating, and they've got elevated methanephrin. So this patient has pheochromocytoma, and the unilateral adrenal tumor seems to be the source of their excess secretion of the adrenaline and noradrenaline. So they need to be stabilized initially. So a key thing in management of pheochromocytoma is that you always alpha block before you beta block. And the reason you do this is because if you beta block first, then they have, so if you think about what beta adrenergic receptors are, there are beta adrenergic receptors in the muscles, which when they're activated actually dilate to increase blood supply to muscles, because again, when you are stressed, blood supply to muscles is increased. So this is actually helping to relieve blood pressure and make sure it doesn't go too high. So if you have unopposed beta blockade and your alpha receptors are still being activated, this can precipitate a hypertensive crisis, which is potentially dangerous. That's why we always alpha block first. That will help bring the blood pressure down, and then we beta block, because the beta blocker in this case is not to do with the blood pressure or it's to do with the tachycardia and to keep their heart rate under control. There's a question here. So difference between adrenal crisis and Addisonian crisis. So adrenal crisis and Addisonian crisis are the same thing. So Addison's is the name given when adrenal failure is, when adrenal insufficiency or adrenal failure is due to a primary adrenal cause. So you don't give a combined alpha and beta blocker. You always start the alpha blocker first, then give the beta blocker afterwards. So just to explain again, so beta blockers, so when you think about it, when you stimulate alpha receptors, they cause vasoconstriction, and so that will contribute to increased blood pressure. Beta receptors in muscles, when they're stimulated, actually cause vasodilatation. If I block those beta receptors won't be causing vasodilatation in the muscles. So those will be constricted. Your alpha blockers, so your alpha receptors in the blood vessels viscerally will be vasoconstricted. So you've got generalized vasoconstriction all over the body. So your blood pressure is going to shoot through the roof. That's why we always give the alpha blocker first to help reduce the blood pressure initially, and then we give the beta blocker, so that we don't get this hypertensive crisis. So always just remember alpha blocker, then beta blocker. So pheochromocytomas, so these are catecholamine producing tumors either in the adrenal medulla or in extra-adrenal sources such as the sympathetic chains. So there's the rule of tens. So 10% is usually associated with familial syndromes such as men. 10% are bilateral and 10% are malignant. And 10% are extra-adrenal. So as I said, they're in the sympathetic chains. So in pheochromocytoma can get a number of different ways this presents, but the often classic triad of symptoms is what was said in the question. So headache, episodic headache, sweating and tachycardia, but they can also get shortness of breath, severe abdominal pain and vomiting, episodic hypertension, and generalized symptoms of sympathetic overactivity. So anxiety, tremor, excessive sweating. Okay. So investigations. So in pheochromocytoma, you often have a raised white cell count. I'm not sure why that is, but it often is the case. You would investigate this by doing usually plasma and urinary metanephrines and normetanephrines, and these would often be elevated. Usually it would be, for urine, you'd often do a 24-hour collection of urine to identify the metanephrines there. And then you can do an abdominal CT or MRI, or you can do a isotope uptake scan, localize where the catecholamine secretion is coming from. So here's the management. So as I said before, you need to stabilize the patient before they can have an operation to remove the tumor if it is localized. So you do, as I said, alpha blockade first, because you don't want unopposed alpha stimulation of receptors, because that will cause a hypertensive crisis. You would then beta block afterwards to help control any tachycardia. So, and this, you'd often treat them for about 4 weeks. Post-operatively, you would then measure their urinary metanephrines again to make sure that there's no recurrence, and you'd monitor their blood pressure just to make sure that there's not any post-operative hypotension because of the sudden change in their catecholamine levels. Okay, and as I said, acute hypertensive crisis is what you would precipitate if you give a beta blocker before an alpha blocker. But there's other causes of this. So instantly doing an abdo exam on someone with a pheochromocytoma could put pressure on the adrenal glands and cause them to just release catecholamines. any stressful situation during labor itself, and giving general anesthetic or contrast can irritate the adrenal glands and cause them to release catecholamines. And this would then cause an extreme hypertensive crisis where you get really bad headache, pyrexia, you'll have your other usual features of pheochromocytoma, and you may have ECG changes because you're getting an element of either heart failure or cardiac ischemia. So management is exactly the same as for pheochromocytoma. So initially you'll want to give an IV short-acting alpha blocker to get the blood pressure under control. Otherwise the management is exactly the same. Okay, so moving on to SPA number 7, 50-year-old man went to his GP with a headache and tingling in his hands, particularly worse at night time. On questioning, he realizes that his wedding ring is not fitting him anymore and his shoes have increased in size. So what's the most appropriate first-line investigation for this? And we'll get a poll for this. Okay, most of you put the answer B, which is the correct answer. So this patient has typical features of acromegaly. Seems most likely pituitary tumor because of they're experiencing headaches. Tingling in the hands, this is going to be most likely due to soft tissue swelling in the wrists, which is causing carpal tunnel syndrome. And further soft tissue swelling is going to be the reason why their wedding ring is no longer fitting and their shoe size is increased. So measurement, the first line would be an IGF-1 level, because the growth hormone stimulates IGF-1 secretion by the liver, which then goes on to stimulate the soft tissues growth. Growth hormone itself is not measured just because, again, you get these variations in growth hormone levels, and also it's actually itself quite difficult to measure. IGF-1's a lot easier surrogate to use. Prolactin levels can be measured, but it wouldn't be used to diagnose this, just because growth hormone secreting tumors often co-secrete prolactin as well. One thing to note is that acromegaly itself is actually associated with insulin resistance and hyperglycemia. So measuring glucose levels will be useful, as would an oral glucose tolerance test, if you suspect that they may be becoming diabetic, but that again wouldn't be diagnosing the underlying condition here, which is acromegaly. So acromegaly, as I said, is hypersecretion of growth hormone from pituitary, which is causing soft tissues and bony growth, which gives you your characteristic features, which are here. So you get soft tissue growth of all your body tissues, and that's what gives the characteristic facial features and body dysmorphism. So you get jaw protrusion, you get these enlarged spade-like hands, enlarged tongues, and soft tissue swelling around the neck, which is why they often get snoring and snoring, carpal tunnel syndrome, acroparesthesia, so tingling around the wrists, and they can also get sleep apnea. There are also some more constitutional features of it. So as I said, it can cause insulin resistance, so it can get a degree of hyperglycemia. Growth hormone can stimulate hypertension and increased activity of glands, so you get increased sweating as well. And you can also get disturbance of gonadal function, so amenorrhea and low libido as additional features. Something to think about as well in patients with acromegaly is, do they have a pituitary tumor that's causing secretion? And is this causing a mass effect? So is this compressing the optic chiasm, so causing bitemporal hemianopia? And is it causing headaches because it's giving a bit of an increased intracranial pressure? Okay, so someone has asked here about the underlying cause behind the amenorrhea. Reason for this is in most cases, it's not actually due to the growth hormone itself, it's due to the fact that the actual tumor that is producing the growth hormone is then compressing the other pituitary hormone secreting cells. So they're actually affecting LH and FSH secretion. And that's what's causing your gonadal dysfunction. Okay. So investigating acromegaly. So you have your, so as I said, raised glucose because you're getting this growth insulin resistant. You can get raised calcium and raised phosphate as well because of its effect on bone metabolism. Okay. IGF-1 levels, I said, are increased because they are the intermediary between growth hormone and its effect on the peripheral tissues. And as I said before, oral glucose tolerance tests and other pituitary function tests are very useful. Oral glucose tolerance tests can actually be used to detect growth hormone secretion and see if it should be suppressed. Because when you give a glucose load to a patient, it should actually suppress growth hormone secretion. And if it doesn't, then this is also an indication that they do have acromegaly. And that would be used as the follow-up test following an IGF level being raised. Okay. Pituitary MRI would then be done to assess whether there's evidence of a tumor. And you can do follow-up investigations such as ECG and echo, because acromegaly, as I said, soft tissue growth, and that also affects the heart. So it can cause cardiomyopathy and lead to cardiac failure. Something that can also be a side effect of acromegaly itself is increased risk of colorectal cancer, as you can have increased rates of polyp growth in the colon. The treatment of acromegaly, so the main way to treat it is resect the tumor, so transfemoral surgery is first line. If surgery fails to correct the cause, then you can give somatostatin analogs, so octreotide, which will suppress growth hormone secretion, or you can use radiotherapy on the pituitary gland. Again, if this does not work, then you can give GH antagonists. The reason these aren't used more further up is because they're just a bit expensive to get a hold of. And then to follow up, what you want to do is you want to keep an eye out for potential complications of acromegaly. So, as I said, monitoring their growth hormone secretion through IGF-1 and oral glucose tolerance tests, assessing their visual fields to make sure that there's no signs that the tumor is growing and compressing the optic chiasm, and then also monitoring and also getting the patient themselves to monitor things such as shoe size, taking pictures of themselves and seeing how their actual body habitus is changing over time. Okay, so moving on to the 8th SBA. So again, patient refers to the endocrinology clinic because she's had an ongoing headache for the past month and menstrual period has not happened for the past 2 months. On examination, she's got bitemporal hemianopia and her prolactin level is 10,000. MRI shows a 12mm pituitary tumor. So what's the most appropriate management for this patient? Let's get a poll up for this. Okay, and everyone has put B, transfemoral surgery. So unfortunately, that is not the correct answer in this case. The correct answer is actually cabergoline, and I'll talk about this a bit later on. So in a patient, so this patient has headache and bitemporal hemianopia. So they like to have this pituitary tumor, and the MRI supported this. It's 12mm. And they have disturbance of menstrual period, and the serum prolactin is raised. So it's likely a prolactin secreting tumor, so a prolactinoma. And so the first line treatment for prolactinomas is actually cabergoline. And the reason it's this and not transfemoral surgery is because prolactinomas are one of these rare cases where actually drug treatment itself can actually shrink the tumor. So there's no point putting the patient through surgery when a drug that you can give them will do the case with far fewer complications. Okay, I'll talk about this a bit later on as well. Radiotherapy can be used as well for prolactinoma. Again, wouldn't be used first line. Octreotide can be used if it's also a growth hormone co-secreting tumor. Haloperidol actually stimulates prolactin secretion. so would not be used in this case. Okay. So hyperprolactinemia. So we can think about hyperprolactinemia as in terms of what is causing it. So is it excess production of prolactin from the pituitary itself, so a prolactinoma? Is it, and what you have to think about if you remember your anatomy of the hypothalamic pituitary axis, is you have these hypothalamic dopamine neurons which pass through the pituitary stalk and act on these prolactin secreting cells, and they suppress prolactin secretion. So if these dopamine tracks are interrupted by things such as surgery, trauma, or pituitary tumor compressing them, that itself can cause raised prolactin secretion. Again, dopamine, not antagonists, sorry, dopamine antagonists would also be responsible for increasing prolactin secretion. So things like metoclopramide, haloperidol, and antipsychotics, which are antagonists of the dopamine receptor. And other drugs such as estrogens are naturally by the body encourage prolactin hormone secretion. So if someone's got excess estrogens, that can cause it. So in states such as pregnancy or breastfeeding. Okay, hypothyroidism can cause hyperprolactinemia because TRH actually stimulates prolactin secretion. So in hypothyroid, because of reduced negative feedback to the hypothalamus, that will cause increased TRH production, so that will stimulate prolactin secreting cells. CKD can cause raised prolactin levels just because it's reduced excretion. And finally, physiological causes that I touched on before: pregnancy, breastfeeding, stress, and also postcoitally as well. There can be a raised prolactin level. So features of raised prolactin. So in both genders, you'll get gonadal dysfunction. So in females, it manifests as amenorrhea or oligomenorrhea, and in men as erectile dysfunction. And impotence, in both genders, you'll get infertility and galactorrhea. In females, particularly, you'll get other symptoms such as reduced vaginal secretions. So they may have some dyspareunia. And in both genders, you can get osteoporosis. What is the relation between CKD and prolactin excretion? So the kidneys are responsible for excreting prolactin. So if the kidneys aren't working, prolactin levels will be increased in the blood. That's essentially why. Yeah, answer that question. And again, because it can be caused by a tumor in the pituitary, you need to keep an eye out for local pressure symptoms. So investigations, so you measure a basal prolactin, and this should be a non-stressful venipuncture. I say non-stressful because, as I said before, if the patient is stressed, this can artificially increase prolactin levels. Do a pregnancy test, because again, if they're pregnant, this can cause increased prolactin, and you do thyroid function using these again to make sure they don't have kidney failure and also make sure that they're not hypothyroid. Finally, MRI pituitary will be done to have a look at whether there's a tumor there. As a first-line management for hyperprolactinemia, even if they do have a tumor, is dopamine agonists, because the dopamine agonists are effective in actually shrinking pituitary tumors that are prolactin secreting. Okay, if this fails, or they're having significant mass effect, then you would go for transfemoral surgery with a dopamine agonist or radiotherapy given post-op, if it's deemed necessary. So 9th SPA. Oh yeah, so I've just been informed that there's, so we do have quite a lot to go with this. So we will probably cover this last topic, and then the rest we might have to leave for another session because I think we're running out of time. But we'll just go over this SPA. So a 45-year-old builder presented to a GP with increasing difficulty of moving around construction materials at work. And he says he's been losing muscle mass despite trying to train his muscles. He says he gets regular headaches and feels his vision is worsened. And when you examine him, there is muscle wasting and is evidenced by temporal hemiplegia. So what investigation we do to confirm the underlying diagnosis? If you get a pop of that. Okay, and most you put D, MRI pituitary. So yeah, so MRI pituitary would be important, but you have to think about what is actually causing the symptoms he's experiencing in terms of losing muscle mass and this generalized weakness. And so when we think about what's going on, so yes, he does seem to have a pituitary tumor, but we want to find out what hormones are actually being affected here. Okay, so in this case, we would be doing an insulin tolerance test. Why? Because this patient seems to be having growth hormone deficiency. Okay, so they're losing muscle mass, they're having this reduction in their quality of well-being and their reduced strength as well in their muscles. So the reason we do an insulin tolerance test is because an insulin tolerance test actually stimulates the majority of the pituitary gland hormones to be secreted. Okay. Patient called hypoglycemia. As we said before, hypoglycemia is a body stress, and your body responds to stress by secreting a number of hormones. One of these would be cortisol, and one of these would actually be growth hormone. Growth hormone is also stimulated by body stresses. Okay, so that would test whether growth hormone is being secreted adequately in response to stress. And if it is not, then we can say that their growth hormone secretion isn't reduced. Okay. Short-Synachron test would be the test for if we suspected their cortisol secretion was being decreased, as I said earlier. IGF-1, yes, would be useful. It would be reduced in growth hormone secretion is reduced, but we want to confirm that their growth hormone secretion is impaired. So we want to do an insulin tolerance test to confirm that. MRI pituitary, yes, would be useful to have a look and see whether there's a tumor there. But again, MRI pituitary wouldn't tell us which hormone is lacking here. Okay, an oral glucose tolerance test, as we discussed before, would be used in acromegaly, as that should suppress growth hormone secretion in hyperglycemic states. Okay. Yeah, so the diagnosis in this question is growth hormone deficiency, and I'll talk about the features of that in a second. So, generalized hypopituitarism, number of different causes of hypopituitarism, and it can be classified as whether it's affecting the hypothalamus, is it affecting the pituitary stalk, or is it affecting the pituitary gland itself? Okay. I know we're a bit short on time, but I believe everyone will get the slides, so you can look over the different causes then. But just remember, think about where is the point that the hypopituitary axis is being affected, and that can help localize the source. Okay. If growth hormone is lacking, then what you would get is you'd get these features here. So you'd often reduced ability to perform exercise, reduced strength, reduced balance, causes reduced ability for the heart to contract, so reduced cardiac output, and also can also cause reduced blood glucose as well. Because it's again, growth hormone is one of these hormones which affects generalized metabolic processes. Okay. And if you think about how in acromegaly there was increased sweating because growth hormone stimulates gland activity, in growth hormone lack, they often have dry, wrinkly skin. They don't have that gland activity. Growth hormone deficiency is also generally a state of increased metabolic risk. So you have increased obesity and atherosclerotic development. Okay. Obviously, hyperpituitarism, any pituitary hormone can be affected, and you'd get the features of lacking that hormone. So we've talked about hypothyroidism, we've talked about adrenal insufficiency. Prolactin lack is very rare, but you would just get absent lactation. And the other main one is growth hormone, not growth hormone, gonadotrophin deficiency. So you'd get gonadal dysfunction. So in women, this would affect their menstrual regularity, their fertility and libido. In men, this would affect their erectile dysfunction, again affect the libido and generalized muscle mass. Okay. Investigating hypopituitarism. Well, so you do your basal hormone tests for your LH, FSH, prolactin, TSH. They can be measured basally. You don't need to do any dynamic testing for those hormones. And again, you'd look at the target hormones for those pituitary hormones. So your sex hormones, your thyroid hormones as well. Okay. And you can also look at IGF-1 and early morning cortisol if you think those are affected. And then you do your dynamic tests. So if you think only cortisol secretion is affected, you can do a short synaptin, as I said earlier. If you think that growth hormone is also affected, then insulin tolerance test is the way to go, because hypoglycemia as a generalized stress will stimulate the growth hormone axis. Other tests that can be used, but less commonly, are glucagon stimulation tests, and actually using growth hormone releasing hormone itself to stimulate growth hormone secretion. And then later on, you can do an investigation of the cause, such as an MRI pituitary. I think there's a question about pituitary tumors often result in. So they can cause either in equal measure. So pituitary tumors can be either functioning or non-functioning. If they're non-functioning, then they either present as either from their mass effect, or because they compress the rest of the pituitary, they affect hormone production by the other pituitary cells. Otherwise, a pituitary tumor can be hyperfunctioning and be actually responsible for excess hormone secretion. So you can't say that most pituitary hormone tumors are one or the other. Okay. So again, hyperpituitarism, you just treat what hormone is lacking and treat what the underlying cause is. So we've already talked about replacing cortisol, and as I said before, if they are lacking cortisol and they're lacking thyroid hormone, make sure you've replaced the cortisol before the thyroid hormone, as giving thyroxine before cortisol can actually precipitate an Addisonian crisis. Okay? In hypergonadism, you again replace the relevant hormones. So in males, you replace testosterone, either intramuscularly or topically, usually. In females, if it's obviously in postmenopausal women, they are going to be hypergonad anyway, because they would have gone through the menopause, so they can have HRT if they're symptomatic. In premenopausal women, you would usually replace their hormones, usually using things such as oral contraceptives. If they still desire fertility and they're still able to, and they still have reproductive potential, then they need to have replacement of the actual gonadotrophins themselves, so LH and FSH injections, because LH and FSH themselves are needed for gamete production, okay, or maturation. And if they're thyroxine deficient, then give thyroxine. If they're growth hormone deficient, then you would give somatotropin injections, so which is a growth hormone analog. Okay, so I think we're running out of time, so this will probably be the last thing we'll cover. So pituitary apoplexy is just something to be aware about, and that's if you get sudden deterioration in hyperpituitarism. So often what will happen is you have a pre-existing pituitary tumor which has a bleed into it, and that would mean that you suddenly get a reduction in all the hormones that your pituitary gland is producing, and then the target hormones are also reduced. So you get these features of a pituitary mass And you can also get meningism. So it can sort of seem like a subarachnoid hemorrhage in presentation. Okay. So to manage this, you need to give them the urgent steroids because, as I said, they're going to be lacking cortisol. They're going to be in an Addisonian crisis, and give them fluid replacement, replace the rest of the hormones as needed, and they most likely will need to be assessed for surgery. And the other extreme is a hyperpituitary coma, which again presents similarly to pituitary apoplexy, where you get end-stage cardiovascular collapse and low GCS. But this is usually more of a slow burning process, and it's sort of the end stage of pituitary hormone production failing. So you get symptoms of all the pituitary hormones being non-functioning, and you also get your generalized signs of there being pituitary tumor if there is one. Again, managed in a similar way to a pituitary apoplexy, where you replace the cortisol first, and then you can replace all the other hormones. Okay, so I think, what's this? I'm not sure how we're doing for time. I think we might need to finish there. So let's see. I don't know. I think we have time for probably one more condition, and then we'll stop. So we'll just do this final SBN and final condition. So a 45-year-old man recently had a transmural resection of pituitary tumor, and he's come for his follow-up appointment. He's now feeling very thirsty and passing large volumes of diet urine with a capillary glucose of 6.1. What's the most appropriate investigation to confirm the diagnosis? Okay, so most of you put C, so water deprivation test, and yeah, that is the correct answer. So this patient has classical symptoms of diabetes insipidus, so polyuria, polydipsia, and the most likely cause of this is going to be cranial diabetes insipidus, because they've had this previous history of surgery on the pituitary gland, okay, which would have disturbed ADH secretion. So yeah, a water deprivation test would confirm the diagnosis. Pituitary MRI, again, might be useful, but wouldn't confirm they have diabetes insipidus. Oral glucose tolerance test would not be needed. They have their glucose measurement is normal, so it's unlikely that they have diabetes, which is responsible for their polyuria and polydipsia. So oral glucose tolerance test isn't needed. Schnorr-Knacklin test would not be used here because they don't seem to have any adrenal cause here. And urine MCNS, again, it might be useful if they're passing large volumes of urine just to make sure they don't have a UTI. But again, based on the history they're presented with, the most likely diagnosis is diabetes insipidus, and urine MCNS would not be the confirmatory diagnosis. So just quickly on diabetes insipidus, so can be divided into either cranial or nephrogenic. Cranial diabetes insipidus, basically anything that affects the brain could potentially cause it. So any tumors, any traumas, such operations or brain injuries, autoimmune causes, infections in the brain, vascular events in the brain, infiltration or inflammatory processes in the brain, or defects in the actual ADH gene itself can cause it. But in most cases, it's actually idiopathic. We don't actually find an underlying cause. Okay. Nephrogenic diabetes insipidus can be inherited. There can be some metabolic causes. So your electrolyte imbalances, typically hypercalcemia or hypokalemia. Drugs can cause it, most commonly lithium. CKD can be a reason for them to have it. And also, if they've recently had obstruction of their urinary tract, which has now been resolved, they can have initially a period of diabetes insipidus. So yeah, sorry. So diabetes insipidus is because they do have either they have low ADH, or their ADH is not acting as it should be. or there's some degree of resistance to ADH that is being released. Okay, so cranial diabetes insipidus is often ADH is not being secreted, or is non-functional. Nephrogenic diabetes insipidus is often because the actual collecting ducts in the kidneys have become resistant or non-responsive to the ADH. Okay, so features, the main features are polyuria, polydipsia. So that should make you think about it. Often with large volumes of very dilute urine. And they can also present with some features of hypernatremia. Okay. So the main investigations for this is measure urine and plasma osmolality. Okay. So when you look at their osmolality, the urinal osmolality should be low because it's very dilute. Plasma osmolality is often raised because they're excreting this large volume of urine, so they're often actually dehydrated. Again, your measure you use needs calcium and glucose because you want to make sure that electrolyte imbalances or diabetes are not the reason why they're passing large volumes of urine. So then you would do your water deprivation test as your main diagnostic test. So you're depriving them of water for about 8 hours, and then looking about whether they adequately concentrate their urine. If they do not, then that will confirm the diagnosis of BI, and then you can see whether it's cranial or nephrogenic, why then give them desmopressin, which is an ADH analog, and then seeing whether they're able to concentrate their urine then. If they're still not able to concentrate their urine, then it's going to be nephrogenic. So management. So if they've come in and they're presenting very dehydrated, polyuria, polydipsia, very dehydrated, then you need to make sure they have strict fluid balance and urease balance. You're monitoring this regularly, and you need to make sure that they're having fluids to keep up with their urine output. And even if they're very hypernatremic, so above 170, you still need to replace with 0.9% saline or crystalloid fluid because you need to maintain that intravascular volume of fluid. And you don't want their sodium to be dropping too fast. So if their sodium is dropping at a rate of more than about 10 to 12 millimoles per liter a day, then they're at risk of central pontine myelinolysis. So they get demyelination of central nervous system tracts, and that has potentially serious side effects and can lead to paralysis. That's why we don't want their sodium levels reducing too fast. And another thing we don't want the sodium levels reducing too fast for is because it can actually cause cerebral edema. So that's why even if they are hypernatremic, we still give 0.9% saline because we want to make the sodium levels reduce slowly. If it is cranial diabetes insipidus, then MRI head, look for any pituitary tumors there, and then we'd also do a dynamic pituitary function tests like the ones I talked about earlier to see if there's any other pituitary hormone imbalance, and we can then give the patient desmopressin, which is the ADH analog, and that should hopefully help to resolve the problem. If it's nephrogenic, it's a bit more difficult to treat. So we treat the underlying cause, and if it's still persistent and they've still got diabetes insipidus, then we can give treatments such as benzo, flumethazide, or NSAIDs. And the thinking behind this is that if we're giving these diuretics and they're then losing this excess sodium, then their body is going to react through alternative mechanisms to retain fluid rather than through the ADH mechanism.